Can you see my slides? Can you see my slides?
Yes, we can see your slide, Dr. Helmi.
Okay, thank you. So thanks again. So I'm going to kickstart the MMIG Fungal Awareness Week, which is the first, the inaugural awareness week that we are having by MMIG by delivering this talk titled 5 Common Diagnostic Errors in Invasive Fungal Infection and How We Can All Avoid Them. So I am using this as a major source for my talk today, which is a publication that is published just a few months ago in Clinical Microbiology and Infection, where the title is Beyond Guidelines, What Do We Need to Know When Dealing with Fungal Diagnostic? But before that, a short disclaimer, I am an ID physician, not a fungal expert. So I'm just pouring some thoughts as I continue to learn in managing IFI. So let's talk about the burden of fungal infection worldwide. So this is a paper that was published back in 2017, looking at the burden of fungal diseases in the world. So as you can see on the right, the top 2 organisms that are causing 4 million infection and diseases are by Candida and Aspergillus, compared to PJP, Cryptococcus, and Histoplasmosis. So the burden of these fungal diseases are mainly driven by these 2 organisms. Therefore, I'm going to focus on these 2 organisms causing IC and IA. So what is IC? So IC is invasive candidiasis, where Candida is the leading cause of fungal BSI or bloodstream infection. As you can see, it is associated with high mortality rate up to 60%. And the incidence is rising currently because of ICU admission, immunosuppression agent, as well as the use of broad-spectrum antibiotic. And once a patient is admitted in ICU, they have these intravascular devices that can breach the skin and cause a portal of entry for the Candida to enter the bloodstream. So what is IA? IA is invasive aspergillosis. It is caused mainly by A. fumigatus. Again, the mortality is high, exceeds 50% despite antifungal therapy, and occurs primarily in immunocompromised patients. But lately, we are also seeing this IA in critically ill patients, especially in ventilated patients, and in COVID-19 patients who are receiving systemic steroid therapy. So I'm going to talk about the 5 challenges that I am facing as a physician in terms of Candida infection and invasive aspergillosis. How do you interpret urine, respiratory, and blood culture result? The role of non-culture methods such as beta-D-glucan and galactomannan, and how do we identify key features for IA using CT scan changes? So let's begin, okay? First error that I usually see as a physician, especially during consult or referral, is that physicians tend to put too much faith on positive urine and respiratory Candida culture results. Whereby when you have this organism in the urine sample, usually it shows that the patient is having colonization. And the positivity in the sample lacks specificity and predictive value for IC, especially when you are talking about candiduria. Candiduria may signal invasive candidiasis, especially with multi-site colonization. However, definitive evidence linking candiduria to IC is lacking. Therefore, when you have positive culture in these samples, you need to stop first before you start the patient on antifungal and ask yourself whether the patient is truly having IC or not. And again, I'm talking about Candida here. It is common, especially in ICU patients, where it likely represents heavy colonization such as CBD use, broad-spectrum antibiotic, critical illness, as well as the use of intravascular devices. But my advice on this is that when you see candiduria, do not totally forget it or ignore it, especially when you are dealing with neonates, immunocompromised patients, and those with obstructive uropathy. You should actually investigate further because the patient may still have IC if they have candiduria presence, okay, in this patient, especially in neonates. The second error is we put too much faith on negative blood culture results. And I will actually tell you further what does this mean, because negative blood culture result for fungemia in high-risk patients may still mean that patient can still have IC. So blood culture is a gold standard for IC diagnosis, and this is being supported by international guidelines. And in IDSA guideline, it is mentioned 40 times. I just looked through it and then count. There are 40 mentions of blood culture in the documents. But the problem is blood culture are notoriously insensitive, where viable candida are rapidly eliminated from the circulation. So for me, blood culture is not so golden after all, right? Yeah, although they say it is gold standard. So this is a study looking at, so they are missing 50%, up to half invasive candidiasis can be missed in the blood culture. So what do I mean with that? So this is a study looking at post-mortem patients, autopsy studies of invasive candidiasis. So this patient has confirmed invasive candidiasis based on autopsy findings. And then they actually then linked up these autopsy findings to the previous blood culture positivity. As you can see from these 13 studies, majority were involving hematological malignancy patients or acute leukemia. You can see that the median sensitivity for blood culture was only 44%. That corresponds to that 50% missing candidemia in patients with invasive candidiasis. Therefore, my tips for you, if you're a physician, how do we improve IC diagnosis? First, be aware that in high-risk patients, negative blood culture do not rule out IC totally. And when you collect the blood culture to investigate for fungemia, you need to optimize the volume, the site, and the incubation. What do I mean with that is when you take the blood culture, try to take at least 3 sets of blood culture from 3 different venue puncture sites, incubate for longer, at least 5 days, and then if the CT scan changes or ultrasound show that the patient is having abscesses in the liver or in the spleen, you may want to think about collecting cultures and send HPE from this infected site. And then there is also this role of adjunctive diagnostic tools such as biomarkers, BDG, CATA, menin, anti-menin combination, PCR, as well as imaging. The imaging is not available in Malaysia currently. But be aware also, I said just now for the tip number 3 and tip number 4, right? For the tip number 3, sterilely collected culture from the infected tissue is invasive, especially when you're talking about hematological patients who have low platelet. This can actually be invasive and be causing harm to the patient. Plus, you must remember it has limited sensitivity. But if you combine both these infected tissue culture sampling as well as blood culture and the non-culture method like serum BDG, you may increase the detection rate of IC. So you usually use this in combination. And possible reason why this collected culture from the infected tissue can be negative is uneven distribution or there is low burden of viable organism in the tissue. And what about the non-culture method? They are helpful to make the IC diagnosis, but you must understand their limitations. Diagnostic stewardship is important. You shouldn't be sending these biomarkers without thinking about the pretest probability and the host or the patient characteristic. And positivity, for example, for PCR does not equal to viable candida because PCR can also detect the non-viable candida in the blood or in the tissue samples. So what are error number 3? So let's delve further into this non-culture method like serum BDG. So we should not send serum BDG indiscriminately. Okay. So let's break down what BDG is. BDG is cell wall components of these fungi, Candida, Aspergillus, Pneumocystis, and Fusarium. And you must understand that in some bacteremia, bacterial BSI, it can also cause false positive BDG. Like in this study that was published in Japan, the positivity rate was 12.8%. Wow. And then it can also cross-react with the following that can cause false positivity. So hemodialysis filter, beta-lactam antibiotic like piptazo, and the use of immunoglobulin. So before using this, you need to know what can cause positive BDG as well as what can cause false positive BDG. And what are the good things about BDG? It can provide early signal for IC, where it can become positive before the blood culture is positive in IC, especially in patients with deep-seated candidiasis or non-candidemic disease, where the patient may, in one example, the patient can have liver abscesses due to candida due to neutropenia, but the patients may not have candidemia or have transient fungemia, causing the blood culture to be negative in this patient. So BDG can help detect IC in this patient, especially in hematological malignancy and neutropenic patients. It also covers non-candidemic IC, as I said, useful in deep-seated candidiasis, and it serves and has a high negative predictive value, meaning that if you have negative BDG result, especially serially, it can help rule out IC and avoid unnecessary antifungals in our patients. But let's talk about the bad things of serum BDG. It has poor specificity, where when it becomes negative, it is good, but when it is positive, it is a bit difficult to interpret. And then the other thing is that the turnaround time. Usually BDG often batch in many labs, which delays the results. So if it is negative, as I said, chill. But if it is positive, you need to pause a bit because it is a good rule out test when it is negative, but think carefully when the test is positive. So tips to improve the BDG use. Before using it, think about the pretest probability in your patients. You shouldn't actually be sending it in patient with low risk for IC and the patient characteristic. Repeating a test and combining, as I said just now, 2 or more biomarkers, as well as CT scan or imaging, can improve the sensitivity and specificity of disease detection, disease here being IC, and best to incorporate biomarkers with diagnostic stewardship. And tomorrow, Dr. Amira will talk further on BDG and how to use it. So I want you guys to actually stay tuned if you have time tomorrow or free tomorrow. So this is the part 2 of the talk today. So the part 1 is talking about IC or invasive candidiasis, and now I'm going to talk about invasive aspergillosis. So there are a few diagnostic challenges in invasive aspergillosis. First, it is non-specific in terms of clinical features. Again, culture method like in invasive candidiasis is limited for invasive aspergillosis, and we need to rely heavily on biomarkers and imaging to make the diagnosis. So before we move to the fourth error, I just want to actually touch on the blood culture in Aspergillus. So Aspergillus infection seldom produces fungemia that is detectable by blood culture, except in A. teres, because it can cause this in vivo conidiation, or meaning spore formation into the blood culture that may be picked up by the blood bottle that can be positive. Okay. So biomarkers, as I said, play a role in IA diagnosis, especially galactomannan. So let's go through on how to stent it properly. So I think that we need to actually understand how to stent this galactomannan and shouldn't be sending galactomannan from all the sites. We need to actually match the test with the patient characteristic and the pretest probability for the patient to have IA. So what do I mean with that? Okay, so this is a nice nice picture to show how IA can happen in neutropenic and non-neutropenic patients. So let's talk about the neutropenic patient first. When they have neutropenia, what happens is that when this aspergillus is in the airway, it is neutropenia is present, so it abolishes the first bronchoalveolar containment, meaning that it will not be contained in the airway. It has a short airway phase, which is about 24 hours, and it rapidly will penetrate into the lungs parenchyma, causing this rapid angioinvasion and early vascular invasion by the hyphae. So what is the diagnostic implication of having short airway phase and then the rapid angioinvasion? You have little opportunity to recover the fungal element for respiratory secretion, meaning the positive rate in this patient for BAL is very low. But because of the angioinvasion, it releases the galactomannan into the blood, making the serum test to be the method that you should be using in neutropenic patient. How about in non-neutropenic patient? In the non-neutropenic patient, it is the reverse. They have a prolonged airway phase, days 2 months, because they have intact neutrophils that delay the injo invasion. So they have a lot of this ulceration and disease burden in the airway, but the organism or the hyphae will not angio invade, or when they angio invade, it will be delayed. So what is the implication here? You have a high yield from respiratory secretion. So when you send BAL, usually the BAL positivity rate if the patient have IA is very high. But because there is lack of angio invasion, there will be low serum biomarker in this low serum concentration of galactomannan in the in the blood lah. So side by side, neutropenia and non-neutropenia. Again, this one is for the airway. So aspergillus grows in and around bronchial mucosa or submucosa, and ulceration can be seen in non-neutropenic patients where they have high local burden of hyphae shedding into airway secretion, and the hosts are usually transplant patient or critically ICU patient with influenza or patient with CAPA, which is COVID-19 associated pulmonary aspergillosis. So this red one is refers to the neutropenic patient. So in this patient, because they have short airway phase, aspergillus, as I said just now, break through the blood vessels. They can cause thrombosis, infarction, hemorrhagic necrosis, and fewer hyphae are free in the airway secretion. So the BAL tended to be negative in neutropenic patient. So the hosts that usually have these changes would be having profound or prolonged neutropenia, for example, AML patients on induction chemotherapy. So, summarizing everything, tips to GM testing in this in these patients. Before sending it, again, like GM, you need to think about pretest probability and patient characteristic. If the patient is neutropenic, send serum galactomannan. Non-neutropenic patients, send BL galactomannan. Post-transplant patient, again, send BL galactomannan based on the discussion that we had just now. Though when I actually look at this paper, which is having PMID like PMID of this, you can see that the sensitivity is 58% or in kidney transplant and 55.6% to for liver transplant, which is a bit higher than patients who are in ICU, which was about 13%. If you're talking about serum galactomannan, okay. So maybe in the post-transplant patient, you can combine BAL galactomannan with serum galactomannan. But I'm taking this from the guideline that is there in the PMID. So different tests for galactomannan, they have different cutoff, like ELISA versus non-ELISA, and the interpretations may differ. Again, if you want to learn more, stay tuned to our lecture tomorrow by Dr. Amira. The last one, chasing the halos in everyone. I bet some of you have here before, if the patient have invasive aspergillosis, you need to look for the halo sign, air crescent sign in your patient in the CT scan. But I think we need to stick with contact, not just looking for the glow, okay? So I'm using the same picture just now, same figure, but I just want you to concentrate on this in angio invasion. So the angio invasion is usually seen with neutropenic patients, but not in non-neutropenic patients. And this implicates the CT scan changes. The angio invasion can lead to this halo sign, and later as neutrophil recover, the patient will have a crescent sign. So what does this mean? It means not everyone gets a halo. So classic halo and A crescent are uncommon in ICU patient and solid organ transplant. The common changes in solid organ transplant patient are as follows. They have consolidation, large nodule, or ground glass changes. Rarely they have halo of A crescent sign. So you should not actually be limiting yourself to these changes if you are talking about non-neutropenic patient like solid organ transplant patients. So tips to imaging or CT scan in patients with IA. If the patient have an early disease of IA, classical sign even in neutropenic patient may not be present. In these patients, repeat scanning may be needed if suspicion remains high. Tip 2, you must actually ask yourself whether you are dealing with neutropenic or non-neutropenic patients, because radiological appearances differ, as well as galactomannan positivity differ in terms of serum as well as BAL. Halo sign is not specific even in neutropenic patient. The patient, again, you need to think about this pretest probability. The patient can even have non-infective causes like hemorrhagic mass or septic emboli, or angioinvasive moles such as mucormycosis. And absence of halo or A crescent does not rule out IA, especially in non-neutropenic patients. And I think this is the end of my slides or my presentation. Thank you.
Thank you. Thank you, Professor, Associate Professor Dr. Helmi bin Sulaiman. Okay, for the excellent talk.
We will now move to our second session by Dr. Low Lily, who will present on 5 common therapeutic mistakes in IFIs and how to avoid them. Dr. Lau, kindly proceed.
This allowed me to share my slide. I'm not allowed to share slides. Could someone help me with this?
Just wait for a while, let me unshare. Stop share. Okay, done.
Okay, can I have a quick check? Can everyone see my slides?
Yes, Dr. Low, is clear.
All right, good. So good morning. My name is Lily, Infectious Disease Physicians. So thank you for joining us today. So, and happy Malaysia Day. And today is also we're celebrating the Fungal Disease Awareness Week, a week that we try to remind people about the burden of disease of fungal infections. So my topic today is 5 common therapeutic mistakes in the management of IFI or invasive fungal infections. So what I'm going to do is I'm going to share 5 case scenarios, which I think these are the practical problems that we are facing day in and day out in our clinical practice. So we are moving away from voodoo medicine. We're no longer practicing antifungal therapy like those many decades ago. Now we have more appealing and choices of antifungal agents. So this is a case scenario number 1. Here we have a 40-year-old gentleman diagnosed to have acute myeloid leukemia, post-induction chemotherapy with neutropenic fever and hypoxemia. So he was treated as invasive pulmonary aspergillosis. So he was started on voriconazole for the IPA. On day 15 of voriconazole, he started to complaining of seeing objects crawling on the ceiling, so associated with some headache. So based on the complaints, there are a whole list of possibility or differential diagnosis. Some of it, we might think of the aspergillosis with extension to the CNS system, or intracranial hemorrhage as in view that this patient has got a very severe low platelet count, or leukemic infiltration of the CNS system, or voriconazole toxicity. So the treating team quickly perform a CT brain with contrast. Of course, the CT brain shows that there was no abnormality. So the dilemma here is, are we going to proceed with the MRI brain to make sure that there's no other pathologies in the brain, or are we going to consider lumbar puncture, knowing that this patient has got a very severe thrombocytopenia? So he was started on voriconazole actually based on the body weight. That is quite a standard dosing, 200 mg per day. So luckily, this patient, we had performed the measurements of the serum voriconazole level. At day 5, during the steady state, the voriconazole concentration actually was within the therapeutic range, that was 2.4. On the day 15 of voriconazole therapy, that was coincide when he was start complaining to have the visual hallucinations. The level was actually strikingly elevated, 8.9. That is beyond the therapeutic range. So what I'm trying to say here in this case is, one size doesn't fit all. The standard dosing that we usually use doesn't actually means that it's suitable for all patients. So voriconazole is a very interesting drug. okay, because it's got a very large inter and intra-patient PK variability, and the pharmacokinetic profile is non-linear. Therefore, the serum concentration is not predictable. And the metabolism, most of it is metabolized via the CYP450 enzyme in the liver. Therefore, genetic polymorphism of CYP2C19 has got a great impact on the voriconazole concentrations. So what I'm trying to say that when you're using voriconazole to treat systemic infection, it's very important that we monitor the therapeutic drugs level carefully, and based on the guideline that available, what is the acceptable range of TDM. So exposure toxicity relationships. Neurotoxicity of voriconazole is more frequently seen when the concentration is above 5 mg per liter. Okay, in fact, in Asian populations, a trough concentration above 4 is already considered associated with increased risk of neurotoxicity. And when a trough concentration of more than 3, we already have to worry about the possibility of hepatotoxicity. So which antifungal agent that need TDM monitoring? Okay, drugs that with narrow therapeutic range, or drugs that with a very variable in the pharmacokinetics profile, or drugs that whereby there's been proven clinically there is a dose toxicity relationship or dose response relationships. Okay, antifungals that usually require TDM monitoring inclusive of itraconazole, voriconazole, posaconazole, and flucytosine. Usually amphotericin B, fluconazole, and echinocandins does not require routine TDM monitoring. So this is some of the international guideline that mentions about the TDM monitoring, Japanese guideline, the Australian guideline, the British guideline. In fact, in the ECMM guideline for the management of aspergillosis or mold disease, there's a small chapter about the TDM monitoring. Then, of course, in Malaysia, we also have our guideline on antifungal pharmacokinetics. We are encouraged you to monitor the TDM if you are using itraconazole, voriconazole, or posaconazole as a treatment for systemic fungal infections. So moving on to case scenario 2, here we have a 35-year-old gentleman, post-laparotomy for perforated viscous. Post-operatively, he was monitored in ICU. In fact, he was ventilated with prolonged ICU stay. He had prolonged fever despite broad-spectrum antibiotic, and he was put on TPN. Blood culture grew yeast cell, and therefore he was started on anidulafungin. So fever responded with the anidulafungin therapy. So blood culture was repeated 3 days after the anidulafungin, and it was reported to be sterile. So eventually the yeast from the blood culture identified as C. tropicalis. So vital sign remained stable. He was afebrile. Ultrasound of the abdomen shows that there was no intra-abdominal collections, and there was no clinical or imaging findings of infective endocarditis. So the plan is to complete the anidulafungin for 2 weeks, counting from the time whereby the blood cultures was sterile. So the question here is, do you agree with the approach of continuing anidulafungin for the entire treatment course? So is it better to use the fungicidal drug like anidulafungin versus other drugs, for example, fluconazole, which is actually fungistatic? So let's take a look about the tropicalis. Yeah, azole-resistant tropicalis is increasingly reported in Asian Pacific region. C. tropicalis has lower susceptibility to fluconazole than C. albicans, and C. tropicalis susceptibility to fluconazole was the lowest in Vietnam and in Thailand. We do not have the data for Malaysia as a whole, but in my center, I've noticed that around 20% of C. tropicalis actually resistant to fluconazole. So the resistance is mainly due to the overexpressions of the ERG11 and UPC2 genes in the C. tropicalis itself. So for these patients, the C. tropicalis shows that the MIC is actually susceptible to all the antifungal agents, namely the fluconazole, the voriconazole, micafungin, and also the casfofungin. So is it safe to de-escalate to fluconazole considering that patients still ventilated in ICU? So fungicidal treatment is always better than fungistatic. And this patient, he has got the normal liver functions, although he has got mild renal impairment with a creatinine of around 200 micromole. So fungistatic drug versus the fungicidal drugs. So this is a meta-analysis to look at to compare the two fungal therapy in the patient's non-neutropenic in ICU. The pool odds ratio shows that fungicidal therapy demonstrated a better early therapeutic success, and that also less persistent or recurrence of infections if we're using fungicidal drug versus the fungistatic. But as a whole, there's no improvement or no difference in terms of survival. So this is another study comparing the fungistatic therapy and fungicidal therapy among the pediatric population with candidemia. Again, fungicidal here, they're referring to amphotericin B and caspofungin versus the fluconazole treatment in the fungistatic arm. There were no statistically significant difference in mortality between the patients that whereby either they receive ampho-B, caspofungin, or fluconazole. So this is an evaluation of the step-down therapy from the anidulafungin to oral azole. So this is an open-label, non-comparatively study among the patients with either candidemia or invasive candidiasis. They were treated with the IV anidulafungin. At day 5 of therapy, they have given an option to step down to oral azole, either fluconazole or voriconazole, depending on the sensitivity, provided that patients already afebrile for more than 24 hours, hemodynamically stable, they are not neutropenic, they have documented clearance of candida from the bloodstream, and they're able to take orally. And comparing the two arms, global response, clinical response, and pharmacological response, there's no difference. Either you continue with IV anidulafungin or step down to oral azole treatment. The highest successful global response rates were noted for among the patients infected with C. albicans. But as a whole, a short course of IV anidulafungin followed by early step down to oral azole therapy is an effective and well-tolerated approach for the treatment of candidemia or invasive candidiasis. So this is an MR-CAN2 study data, multi-center prospective trial, again to look at the step-down treatment among the patients non-neutropenic in ICU. The conclusion of the study shows that in non-neutropenic critically ill adult patients with documented or suspected invasive candidiasis, antifungal de-escalation within 5 days not related to increased 28 days mortality, but it was associated with a decreased antifungal consumption, meaning that we save some of the antifungal agent that used unnecessarily based on the DDD. Sorry for that. So another post hoc analysis based on a 3-cohort study, looking at the step-down therapy from echinocandin to fluconazole in the patient with candidemia. Again, early de-escalation had no significant impact on mortality, and early de-escalation is a safe strategy in patients with candidemia caused by fluconazole-sensitive strains, whereby the source control has been done properly and the blood cultures already been sterile. So this is a systemic review and meta-analysis to look at the escalation therapy based on 9 studies that have been published.
Dr. Lily, the slides are not moving.
Oh dear. Can you see now? Is it moving now?
You're still stuck in MR-CAN2 study data.
Okay, I may have to log out and log in again. Does it move now?
No, still at
Still no. I think I need to unshare it. Studies to look at the early step down from echinocandin to fluconazole treatment in patients with candidemia. Again, the study result shows that early de-escalation had no significant impact on mortality, and early de-escalation is safe strategy in patients with candidemia caused by fluconazole sensitive strain, whereby the source control has been done appropriately and the blood cultures already been sterile post-treatment. So this is a systemic review and meta-analysis based on 9 studies on candidemia. And again, the study result shows that the mean days of the escalation was only 5.2. And as a whole, the escalation is a safe strategy. It shows no significant higher 30 days mortality and a trend towards a greater clinical and microbiological cure. So in fact, if we look at the management bundle or the management cascade for invasive candidemia or invasive candidiasis, step down to fluconazole is one of the approach that been mentioned in the management guideline of ECMM for the candidemia management. So even though it's encouraged to start echinocandins as empirical treatment when the blood culture grew yeast cell, but as you know that when the culture is true, if it's sensitive to fluconazole and patient is relatively stable and the culture clearance is already achieved, you may consider to step down to oral fluconazole treatment. You do not have to continue echinocandin for the entire treatment course of 2 weeks. So moving to the scenario 3, this is a continuation of the previous patients. So these patients was actually still intubated, right, in ICU, okay, with the FiO2 only 0.4, no inotropic support, and the treatment team, maybe after this lecture, they convinced that fluconazole is working, therefore they escalated to fluconazole treatment, and the creatinine, as mentioned earlier, was 200, is slightly impaired. So as we know that fluconazole is mainly excreted by the kidney. So therefore, in a patient with renal impairment, we had to adjust the fluconazole dose according to the renal profile. So for these patients, the fluconazole was given at 200 milligrams stat and daily. So I would like to know about your comment about the fluconazole dosing. Do you agree with the 200 milligram daily in view that this patient with the eGFR of less than 50? So fluconazole, as you know, it has got a very high oral bioavailability, half-life about 30 hours. Therefore, without the loading dose, you can only achieve the steady state more than 7 days with the daily dosing. If we give the loading dose, the steady state could achieve faster, less than 7 days. And 80% of the fluconazole actually been excreted in the kidney. So the fluconazole clearance, mainly by the kidney, in a patient with normal renal functions, the clearance is about 20 mL per minute. But however, in the patients that are undergoing continuous renal replacement therapy, the excretion or the clearance is actually faster, depending on the mode of renal replacement therapy, the filtration rate, and also, of course, the filter that been used. So in fact, in the critically ill patients, there are quite a number of reports mentions that based on the PK/PD calculations, even in the patients that with normal renal function, because of the augmented renal clearance in the critically ill patients, you probably have to consider a higher dosed fluconazole in the critically ill patients. So this is taken from the Nephrotransplant Journal. So it mentions here, if you're using fluconazole to treat systemic candidiasis, we need a loading dose, 800 milligrams, followed by the maintenance dose, whereby the maintenance dose you have to calculate based on the eGFR or the creatinine clearance, or depending of the type of dialysis. So this is another paper that quoted from the Pharmacotherapy Journal. So antimicrobial dosing recommendation for critically ill patients receiving continuous renal replacement therapy. So you need a loading dose, okay, followed by the maintenance dose. So we cannot compromise on the loading dose because that will delay the time to achieve the steady state. So why is loading dose important? The plasma drug concentration reaches a steady state only after about 5 times of the half-life. So if a drug has got a longer half-life, understandably that you'll be taking a longer time to reach the steady state. So therefore, the drug might not reach a minimum effective concentration MEC, if let's say is not followed by a loading dose. At steady state, the rate of the drug elimination is at equilibrium with the rate of the drugs that have been administered. So this will be a problem if, let's say, you are treating a patient that's severely ill, or they have a very large fungal burden, or a disease whereby it's deeply seated, whereby surgical procedure or evacuations cannot be done immediately, or a fungi with a higher MIC. Therefore, we need to assure that the concentration of the drug reach the steady state or high Cmax as early as possible. A loading dose will rapidly achieve the peak concentrations necessary to compete for the clearance and therefore shorten time to the steady state and to the MEC. So the diagram on the left is actually the dosing without the loading dose. It's taking a longer time to achieve the steady state, whereas the diagram on the right is the drug concentration in the blood after a loading dose. Likewise, this is another diagram. If we're looking at the dark line, it's showing you the drug concentration with the loading dose. It achieved the target concentration pretty fast, okay? Comparing to the brown line, whereby the infusion is given without the loading dose, it's taking a longer time to reach the therapeutic range. So all the azoles, namely the itraconazole, voriconazole, posaconazole, azaviconazole, they have actually quite a long half-life. Therefore, it's recommended to start with the loading dose before you continue with the maintenance dose. And just a reminder here, posaconazole is available in 2 different formulations, oral formulation, the tablet formulation as well as the suspensions. The suspension formulation of posaconazole has got a slightly longer half-life as compared to tablet formulations. Therefore, for suspensions formulation, it takes a longer time to reach the steady state, even though with the loading dose. So this is for the anidulafungin. Both the caspofungin and anidulafungin, we need a loading dose. As for micafungin, loading dose is not required because based on the study, it shows that the standard dosing of 100 milligram infusion of micafungins able to achieve the probable target attainment if the MIC or the organism that is considered susceptible. And the graph on the left lower corner is a caspofungin with a loading dose. Look at the dark dot. This is the caspofungin level with a loading dose whereby it could achieve the level above the target easily with the loading dose, but without the loading dose, it takes a longer time to achieve the target above the MIC. So moving on to case scenario number 4, here we have a gentleman here, acute leukemic acute ALL, acute leukemic leukemia. So on itraconazole as prophylaxis, post-chemotherapy, he was neutropenic and blood culture grew actually candida albicans, which is actually sensitive to fluconazole. So the questions here now, this patient's been given adequate itraconazole as prophylaxis. Why should he develop a breakthrough infection while on antifungal prophylaxis? Is it due to the non-compliance or because of the ineffective azole because we're using the generic version of the azole treatment? So retrospectively, when you ask further questions to these patients, this patient admitted that he has been taking PPI, pantoprazole, for the past 4 weeks. So in a ward, we quickly draw the blood for the serum itraconazole concentrations measurements. And true enough that the concentration is actually very low, far below the targeted range that for prophylaxis. So PPI and itraconazole, as we know that the capsule formulation of itraconazole requires acidic environment to enhance the absorptions. So by the co-administrations of PPI and itraconazole, the PPI actually will increase the gastric pH, therefore reduce the absorption of a capsule itraconazole significantly. Therefore, it's not recommended to co-administer PPI with capsule formulation of itraconazole. So if the patient really need PPI, you may have to consider to opt for another type of azole or antifungal treatment. In contrast, suspension itraconazole, the absorption is not dependent of the pH. Therefore, PPI's co-administrations does not have a significant impact on the serum itraconazole concentrations. This is based on in vivo study. And as for the SUBA formulation, that's a super bioavailability itraconazole, the dissolutions and also the absorption happen in small intestine. Therefore, the absorption is not affected by the PPI or the pH of the gaster. But as a whole, in clinical practice, if let's say you need to co-administer PPI with itraconazole, it's always recommended to follow up or monitor the itraconazole concentrations. So, and PPI and posaconazole, suspension posaconazole, likewise, it also requires the gastric pH to enhance the absorption of posaconazole. So therefore, co-administrations with PPI, with the posaconazole, may actually reduce the Cmax or AUC of the posaconazole. So in contrast, the tablet formulation, PPI did not significantly affect the concentrations. This is based on, again, in vivo study. But in clinical study, co-administrations of PPI and posaconazole tablets formulation in adult patients with leukemia actually was significantly associated with decreased trough level of posaconazole. In conclusions, in ill patients, whereby you suspected there will be reduced ability for GI absorptions, or probably there was some problem with the mucositis or diarrhea, in this group of patients, it's still advisable to monitor the posaconazole concentration, even though you're using the tablet formulation of posaconazole. So moving on to the last scenario here, 50 years old, diabetic, okay, diagnosed to have the rhino-orbital mucormycosis. And we know that mucormycosis is one of the most that they're intrinsically resistant to many antifungal agents. Therefore, the treatment option is actually very limited. In this patient at presentation, the patient has got AKI with a creatinine of 120 micromole. So at that point in time, you do not have access to liquid formulation amphotericin B. Okay, and again, you do not have access to posaconazole, isavuconazole, which are the other antifungal agent you can use to treat invasive mucormycosis. So the only option here we have is, of course, our deoxycholate amphotericin B or our conventional amphotericin B. So the recommended dosing for invasive mucormycosis when you're using the deoxycholate amphotericin B is 1 to 1.5 milligram per kg per day. This is quite a high dose. But in view of the AKI, renal impairment, how are you going to dose your patients here so that to prevent further deterioration of the kidney functions? Are you going to start slow with the 5 milligram and increase it slowly over the next few days to 10, 15, 20, and so forth until we reach the level of 1 milligram per kg per day? Or are you going to dose it with a half of the recommended dose, 0.5 milligram per kg per day? Or are you going to start with the therapeutic dose, recommended therapeutic dose, that is a 1 milligram per kg per day, even though these patients that you know that the creatinine is impaired? So you can actually make your decisions and see what is the recommended by the guideline. So this is taken from the mycosis paper, Management of Mucormycosis in COVID-19 Co-infected Patients, the CAPA, right? So if you're using amphotericin B deoxycholate, as mentioned earlier, the recommended dosing is 1 to 1.5. So in order to avoid the nephrotoxicity side effect of the amphotericin B, you need to infuse with normal saline before the amphotericin B infusions. And you have to make sure that you hydrate the patient properly and to avoid other concomitant nephrotoxic drugs. So we do not recommend, or the guideline do not recommend, slow escalation dose and avoid graded dose titration of the deoxycholate amphotericin B, even though patients has got renal impairment. So amphotericin B deoxycholate actually is a very unique drug. It has got 3 phases here. The initial phase after your infusions of amphotericin B, the plasma half-life, it actually varies between 24 and 48 hours, whereby a small portion of the drug at this interval will be excreted in the feces or through the kidney. This drug has got a very long half-life in the tissue of around 2 weeks, with substantial level that accumulating in the liver or the spleen, and to lesser extent in the lungs and the kidney. So then it will come to the terminal half-life, terminal elimination phase, whereby the remaining of the amphotericin B in the body, 40% will be excreted in the feces and another 1/3 will be cleared by the kidney. So based on this, it's very important that we infused or started the patient with adequate dose based on the recommended dosing at the early phase of treatment. This ensures that we achieve the adequate serum concentrations of amphotericin B in the blood level. Therefore, we can assure that there will be adequate that amphotericin B that accumulating in the tissue. Okay. So this is in particularly true when they're dealing with the very critically ill patients, whereby they have a deep-seated infections. We need to make sure that the amphotericin B penetrating adequately into the tissue level so that prevent the mortality. Because a lot of time we're dealing with patients with invasive mucormycosis, patients are not stable enough to go for surgery at the immediate actions. So we probably have to stabilize the patient for a few days before we can bring the patient to OT. Therefore, it's very important when we infuse the antifungal treatment, we make sure that we're giving the right dose, okay, to achieve a good concentration in the blood and therefore with a cumulative dose in the tissue. So we should not compromise the dose of amphotericin B just because the patient has got the renal impairment. So compromising the dose is not the way to prevent nephrotoxicity. The way to prevent nephrotoxicity of amphotericin B is actually to make sure that we're giving the patient adequate saline, meaning the sodium chloride infusion before the amphotericin B, and to make sure that we adequately hydrate the patients and avoid nephrotoxicity drug as a concomitant administrations. I think this is my last slide already. So even though amphotericin B resistant fungi is not common, there are some fungi that intrinsically they have higher MIC towards amphotericin B, for example, the Aspergillus terreus, Fusarium, and also Lemanthospora. So Candida auris is a growing concern globally. So it depends on the clade. Some of the Candida auris is actually resistant to amphotericin B. And I just would like to quote a paper here, nosocomial breakthrough fungal infections among the patients with malignancy that receiving antifungal prophylaxis or treatment. Here in this study, it shows that among patients that receiving empirical treatment with amphotericin B, there was reported a breakthrough fungal infection due to C. albicans, Trichosporon, and also C. lusitanii. So amphotericin B, even though it's a broad spectrum antifungal agent, so breakthrough infection may happen, in particularly when we are not giving adequate dosing. We did not achieve the adequate AUC or the Cmax to prevent the breakthrough infections. So be cautious when you're using amphotericin B when you're treating invasive fungal infection. Make sure you follow or refer to the guideline. With that, I would like to thank you for your attentions, and hopefully we're able to disseminate some information or awareness about the fungal diseases during this week. Thank you.
Thank you very much for the very interesting talk, Dr. Low.
We will now open the floor for Q&A. Please post any of your burning questions in the chat box or in the question Q&A box, and we will read them out to speakers. I see there are 3 attendees with their hands raised. Do you all have any questions, or I will allow you to speak one by one, okay? I'll first start with Nohafiza. Do you have any questions, Nohafiza? Okay, you have put your hand down, okay. Next person, Son or Sun. Do you have any questions for our speakers? Okay, if you have any, then if you don't have a mic, then maybe you can type the question in the Q&A. Okay. Last one, Hannah. Do you have any questions for our speakers? Okay. I see that there is one question here from Rashida, HASA. She has a question regarding tazocin and galactomannan false positive. Is this question directed to Dr. Helmi? I think so. Is it common, and does it affect both serum and galactomannan? Dr. Helmi?
Thank you for this question. I think Dr. Amira will actually speak further on this tomorrow. From what I understand regarding this issue, yes, it happens with the tazocin brand, the previous one. And I think that they have updated the formulation of tazocin in order to reduce galactomannan false positivity. Therefore, I can only say this to be true for tazocin, but I'm not sure about the generic formulation for other piperacillin tazobactam, whether they have tweak the formulation to reduce the false positivity rate. And I think that in Malaysia, locally, we usually use generic formulation. So I am not sure whether the generic formulation can pose the issue. But there is a way of reducing this issue whereby in one of the papers that I read, for you to actually reduce or minimize the issue, remember that the PKPD part of the pip-tazo, especially if you are giving intermittent bolus over 1 hour. So if you want to do that, especially for the serum one, because the serum one will be affected more than the galactomannan, what you want to do is that you will take the patient's serum galactomannan just before the next dose. For example, if you are giving the next dose of pip-tazo at 4 p.m. today, you would want to actually take the serum galactomannan at 3:59 p.m. So that you're going to actually dealing with the trough level of the pip-tazo, especially if you are using the generic form and you are not sure whether it's going to cause the false positivity issue. I hope that that does answer your question.
Okay, thank you, Dr. Helmi. Next question is directed to Dr. Low. Thank you for your sharing. Is it true we have to practice giving 2 pint IV drip before we start IV M4B to reduce risk of AKI? Will it cause increase of volume of distribution? So are going to dose higher if we start M4B and IVD from an anonymous attendee. There is another question as well. I will read that after Dr. Low answers the first one. Thank you.
Yeah. Yes, as I mentioned earlier, to avoid or to reduce the risk of a nephrotoxicity, you are using deoxycholic amphotericin B. First, one of the points I try to highlight here is we need a normal saline. We need a sodium load. Okay, so this is something to do with the afferents of the kidney. So we need to need some sodium to reduce the toxicity of this amphotericin B to afferent tubule of the kidneys. So as to how the amount of fluid that require, whether it's a 1 liter, 500 mils or 200 mils, is really depending on the patient's conditions. So if let's say patient has got a renal impairment or patients already with fluid problem that you need to restrict the fluid, in that scenario, of course, the best to avoid amphotericin B because you can't hydrate the patient properly. The best option is still lipid formulation amphotericin B. But in a situation whereby you really do not have access to lipid formulations, so you probably still need to find a way to give the patients with some hydrating with the normal saline. But in this scenario, we may have to reduce the volume that giving to the patients. So we can't judge every patient as the same. We have to cater the therapy according to the individual patients.
Okay, moving on. What is your opinion on fluconazole dose on the escalation from echinocandin? Once patient achieve hemodynamic stability and culture negative, use body weight 12 milligrams per kg or fixed dose 400 milligram / 800 milligram as you mentioned in one of your ICU paper.
Yeah. So for fluconazole, I tend to use based on the body weight. Usually we do not monitor fluconazole TDM because this is a drug that with a linear PK. So in fact, there's no target range that been set or determined for fluconazole. So even though we do the TDM, it will be quite difficult for us to determine what is the standard target range that we should achieve, although there are some paper based on the critically ill patients. For me, my practice is I usually go based on the body weight, 12 milligram per kilo or accordingly 6 milligram per kilo based on the type of the infection or severity of the infections.
Thank you, Dr. Low.
Thank you, Dr. Low. We have posted on the screen attendance for the attendees. So you can scan the QR code, fill that up. Okay. I have a question for Dr. Helmi. In your experience, which diagnostic error in IFIs do you see most frequently here in Malaysia in our clinical practice, and what practical step can clinicians or laboratories do to minimize this? Thank you.
Thank you for the question, Alia. So I think that the most common error for me, maybe Dr. Lau can also add later, is treating the positive culture from respiratory sample and urinary tract. For the respiratory sample, I think that we should not actually start antifungal in this patient if you are basing only on the fungal culture in respiratory sample and the patient does not have other features to suggest invasive candidiasis. But for the candida in the urine, I also will not start, but I will actually step back first and ask myself if I were to be having this case and ask myself whether this patient is having invasive candidiasis or not. Because what happened is this will actually, when patient have candida in the urine, it may actually tell you that the patient is having colonization, heavy colonization. And if the patient, for example, have any stent in their ureter, or the patient is undergoing procedure soon, so this will actually need to be treated, especially if the patient has selection, for example, in patient with a stent in the ureter and having pus formations or abscesses in the kidneys. And yeah, this is the most common issues that I'm having in terms of diagnostic challenges at the physician end.
Okay, thank you, Dr. Helmi.
Dr. Low, I have a question for you. Given the rise of antifungal resistance, how can clinicians balance the need for early empiric therapy with the risk of inappropriate antifungal usage in these times?
Okay, thank you for the question. That is an excellent questions in this era. We didn't talk about antifungal resistance. Probably that will be touched by the other speaker on subsequent days. So stay tuned for that. So a lot of us aware of the antibacterial resistance, but not many aware about the antifungal resistance, which is actually a rising problem. And it's also a problem of concern because we know that we do not have many antifungal agents that are available as compared to antibacterial. So in fact, based on the antifungal stewardship, we try to promote moving away from empirical treatment to preemptive treatment, either based on the biomarker, fungal biomarker that been explained quite extensively by Dr. Helmi just now, or of course, the best is even the targeted treatment or culture-based therapy. So rather than based on the empirical, whereby you start the antifungal just based on your best guess or your spinal reflex about the condition of the patients, probably it will be a better approach that we adopt or incorporate beta-D-glucan in our treatment or algorithm if we're talking about the invasive candidiasis in ICU patients. As Dr. Helmi mentioned, beta-D-glucan has got a very good negative predictive value. So if let's say in a patient that you suspect to have invasive candidiasis and beta-D-glucan is negative, it probably is safer to off the antifungal treatment. That will reduce the durations and the DDD of antifungal usage. I hope that I answered the questions.
Thank you, Dr. Low. Okay, one more question.
I have there's one more question, and this is to Dr. Helmi. With the increasing use of molecular diagnostics that we have now, do you think conventional methods still contribute significantly to the current misdiagnosis that we get? And how can both approaches be integrated effectively in our setting, patient setting? Thank you.
Thank you. I will actually quote the paper that I said just now, Beyond the Guidelines, that it was published in CMI in July. So if you guys have time, go to that paper and read it. It is only 4 pages long, but it does actually talk about this, the non-molecular and, non-culture and culture-based method when dealing with IFI or invasive fungal infection. So in order to answer that question, it really depends on which fungus you're talking about. So if you are talking about Candida, culture method is still the gold standard, especially the blood culture when we are talking about invasive candidiasis. But when we are talking about things like aspergillosis, this is where the non-culture method plays a role, because it's a bit difficult for you to actually sample the organism from the infected side. So you would actually if you see that there is a lot of this recommendation or guidelines in terms of making that the diagnosis of invasive aspergillosis based on the host factor. For example, when you're talking about hematological malignancy, you need to combine the host factor plus the radiological changes plus the bacteriological findings. And in the bacteriological findings, one of it is the positivity of the biomarkers. So really, in order for you to use this non-culture method versus culture method, you need to know what organism you're talking about, the host factor, the pretest probability, and these positive biomarkers non-culture method should actually be integrated as part of the puzzle to actually answer whether the patient is having an IFI, together with all the things that I said just now, host factors and the patient presentation as well as radiological changes, if any. I hope I answered the questions.
Okay, thank you, Dr. Helmi. There's another question by an attendee. I think you opened the question to both speakers. Is platelet drop considered a risk of fungal infection? The doctor practiced low platelet or blood transfusion before, then empirically they start antifungal therapy. So I guess that's the question. Dr. Helmi and Dr. Low.
Let Dr. Low answer this.
Okay, all right. The question is, I think if I understand it correctly, is thrombocytopenia a sign of the invasive fungal infections? Probably here you're talking about candidemia or aspergillus, not quite sure. So I think common things come first. So there are many reasons whereby the platelet count can drop, right? So you're talking about the severely ill patient, you think sepsis and the platelet drop is a feature of sepsis. So the commonest cause of sepsis is still bacteria. So I would investigate thoroughly for the bacterial cause of thrombocytopenia in septic patients. In fact, in most of the guidelines, either critically ill patient in ICU or we are treating neutropenic patients, it mentions that you need to do a blood culture to make sure there's no bacterial infections. You start the patient with a broad spectrum and antibiotic. In the event that patient do not respond to the antibiotic, yet all your workup for bacteria is all negative, then only you should consider fungal infections. In the event that you do not have a biomarker, if let's say whenever it's practical, you may actually introduce a biomarker to confirm your doubt. So thrombocytopenia is not it can be a sign of the severe fungal infection, but you have to rule out the more common etiology for thrombocytopenia. So not necessarily thrombocytopenia equivalent to immediate antifungal treatment.
And if I were to add, if the patient comes from the community, I would think about dengue first rather than fungal infection.
Yeah, exactly. There are so many causes of thrombocytopenia, isn't it?
Thank you, Dr. Low and Prof. Hilmi. Any more questions from attendees? Please scan the QR code and fill up the attendance form to collect your daily e-certificate and CPD points. Any more questions? Okay, so if there are no more questions, this brings us to the end of day one. Thank you to our speakers and participants. We look forward to seeing you tomorrow at the same time. Thank you.
Thank you, everyone, and have a great day.
Thank you, everyone.